Simulation Happy Hour acknowledges the land and the waters from which you are listening today. Welcome to Simulation Happy Hour. Sit back, relax, and let's talk about all things sim.
All right, welcome everybody to another episode of Simulation Happy Hour. And we have Kerry. Hey, Kerry.
Hi there.
And Jane.
Hi.
And I'm Mel. And we're missing Jenny today, but that's okay. She's a busy lady. And today we're really fortunate to have Dani Gardner with us from the School of Nursing and Midwifery from the University of Technology in Sydney. She's a lecturer and a first-year student experience coordinator and a subject coordinator for the School of Nursing. So, hey, Dani, how are you?
Hi, nice to be here. Thanks for having me.
You're welcome. And so we caught up a couple of times now. So you've presented this work at Simulation Showcase, and then Jane and I caught up with you at the Council of Nursing and Midwifery Deans last year, and we wanted to get you on board to have a chat about your work with AI chatbots within nursing and midwifery. So when we saw you, you had run a pilot study using it. Can you tell us a bit about the pilot study?
Okay, so we did the pilot study in the spring semester of 2024, and I wanted to use AI chatbots in Sim to try and simulate the voice of the patient. And I'd come across a tool called Sim Converse, and I was introduced to this from a colleague at Canberra University, where Jane had been previously. So I know Jane had a bit of experience with this, and I looked at this product. I was playing around with it, and I thought, well, how can we use this at the bedside? So what I did basically is I took the laptop to the side of the bed, and we set it up, with the speakers, and we were trying to just have it at the bedside and create a character that the students could interact with. So we did a pilot study with 3 first-year nursing classes. So it was just set up in one lab. So it was only in the one particular lab, and it was the students on the Monday, Tuesday, and Wednesday morning classes that were all agreed to be in this study. We filmed it using learning space technology so we could actually see what was happening, and we just ran the computer next to the bed space, and the students were to control the conversation by just pressing the space bar. So when pressing the space bar, they would speak, release the space bar, and then the chatbot would respond to them. So
was there a mannequin in the bed? Or?
There was a mannequin in the bed for them to do all of the skills that they needed to do.
Okay.
But essentially what I wanted to do is, I know when we do simulation, we have the actual scenario that's happening, but I wanted to take it back to basics and just do a normal, basic nursing shift, probably a morning shift, where nothing crazy is really going to go on. There's no deteriorating patient or anything like that. But the first year students just had to get consent. Well, they had to introduce themselves to the patient, gain consent to do things, and just explain and give reassurance of what they were doing. So it was very, very basic, but they had to do blood pressures, they had to do temperatures, they had to do pulse rate, they had to do a wound assessment, they had to assess for pain, because I found in the labs, when it's just a mannequin in the bed and it's voiced by their peers or by their tutor, that they're just really practicing their skills, but they're not really interacting with the patient. They're not communicating with the patient. And that's fine to learn your skills, but that's not realistic of a morning shift. If you've got a patient that might have pain, then you have to fix the pain first before you can go on to doing their wound assessment or getting them out of the chair for breakfast or any of those things. So what might take 15 minutes in skills by doing it at the bedside could actually take an hour with all of the other little stuff that's happening. And that was what I was trying to represent for the students.
I have so much to say, but Jane, go.
So, Dani, could you just explain a bit more? Both you and I have used SimConverse, but for our listeners, We've had people talk about chatbots before and they are just written, but this is a verbal communication. So I just think that aspect to converse needs to sort of be clear so that it shows what you're doing.
Yep.
So could you explain that?
Essentially, it's actually a conversation agent. So it's a little bit elevated above a chatbot. A chatbot essentially has pre-recorded responses. So if you're talking with the Commonwealth Bank chatbot, it's got its responses that will answer the questions. Whereas this has linguistic fluidity. Basically, it can go a little bit, I want to say, rogue with its answers, because it can be a bit more experimental. So it is programmed in with its own. It knows its backstory. It knows, well, my patient Justin. It knows his age. He knows his date of birth. He knows where he lives. He knows his story, his medical history, and it can go on with it. Can go with that, but it also uses the web to be able to build on that story a little bit. So, for example, Justin knows where he lives in Sydney. He can use surrounding areas because of what he can find on the internet about that, just to bring out the personality a little bit more. So SimConverse is designed for students to have a remote conversation, or they can have it in class, but it's designed to have a conversation on their device with a patient that's been created with its own backstory, and it's designed to help build confidence and experience with certain situations. So, things like a patient that might be, or an escalating relative that's upset, you can help to de-escalate that situation. But for me, I was making a patient that was in bed. He had a diabetic foot ulcer. He was having difficulty mobilizing. He had some pain. And the first year students just had to navigate that conversation, as I said, to get consent, to introduce themselves, to be able to move on to the next steps, instead of just going ahead and not speaking to the patient and just doing the skill.
Yeah, I love that. So you probably know I have a bent for communication.
Yes.
And so what we tend to find is the clinical skill is broken down in detail, yet the communication element is a tick box saying effectively communicated with the patient tick. And it's not broken down in the same amount of detail. And what I really love about this is what I'm hearing is they have to go through those motions just as much as the clinical skill in order to achieve the goal for that learning activity, which I think is fantastic.
Yeah, well, what I was finding is, and I've said this in my talk before, part of the idea for this was my 15-year-old daughter, who can organise a whole birthday on a WhatsApp chat, but can't even ask for a glass of water in a restaurant. And I'm finding with the students,
that is so true.
The younger students straight out of high school have openly said, how do you communicate? How do you manage teams? How do you speak to patients? How do we learn that? And it is difficult to teach. So, and when they go on placement, you can't standardize the experience that they're going to have. So how can we get the most out of it without using an actor? Using an actor is great, but if we don't have, and it's expensive, if we don't have that resource available, how can we do it in another way? And the great thing about SimConverse is you can ramp up the level of anxiety, or if you want the patient to be a bit obstructive to care, you can ramp that up by recording that. You can make them more anxious. I'd made this patient a bit of a conspiracy theorist, that he didn't trust medicine. And so when you would want to give medications, he would ask and question, what is that? So the students would have to then provide that information.
And so how do you pre-brief the students then to authentically engage with the mannequin, the patient in the bed, but they're tapping the computer?
Yeah, so when we first did the study, it was when because they were having to use their hand to activate the space bar, A lot of the times I would be there with them so they could actually do it, because otherwise there was a lot of hopping back to the space, jumping back and forth around the bed space, and it wasn't as authentic. So I pre-briefed them by doing an example of how I would do it, and just explaining to them that, it was the same patient every week that they were going to be interacting with. So there was no real difference in the scenario, apart from maybe the level of anxiety or the level of obstructiveness that I set. And I would just demonstrate it for them. But I found on the learning space recordings that when I was at the bedside, they were much more interactive with the patient. If I went into the control room and let them do it themselves, they might stop using the sim converse a little bit. So that was an issue. The other thing that I noticed was that because they were doing a wound assessment, they had gloves on, they were then pressing the space bar with the gloves on. So that was a big issue. And so we had to then, I was like, right, I can't teach this because I'm essentially teaching students that it's okay to touch a computer with gloves on.
Yes,
okay.
negative learning.
I didn't want to bring in this infection control issue. So that's when we started working with, we'd already been working with my colleagues in engineering in Fiat, because we had a student, an honours student that was working in the sim labs as a sim technician. And so she decided to use this as her capstone project for her honours. And she's like, right, these are all the problems that we found in those first 4 weeks. And then she built in the next phase of the study, which was adding the microphones around the bed and foot pedals underneath. So instead of them touching the space bar to do it, she built in foot pedals that were placed around the bed space. So when you press the foot pedal with your foot, that would then activate the space bar. So you didn't have to use your hands, your gloved hands. So that was the next stage of the study. And then we just sort of spoke the students through that so they could try using a different way. And that was a game changer.
That's so great, partnering with engineering to come up with a solution. How cool is that? So you have progressed this work since that pilot.
Mm-hmm.
Can you explain where you've gone with it?
Okay, so we found that we had, with the foot pedals, we had much better engagement with the students. They remembered to do it. The conversations got a lot deeper, and it was much easier for them to understand because we had more microphones around. It would pick up the sound of the voices. So the conversations were better because the chatbot was understanding things better. It wasn't mishearing words. There was one day actually where the chatbot, the conversation agent, got cranky with one of the students, and I loved this. And we did talk about it then in the debrief, but it actually raised its voice at one of the students and got really cranky because he couldn't understand her. She was very quietly spoken, and she did have an accent, but we brought that into the teaching, saying, well, you need to be able to handle this type of situation because you will have times when a patient won't have their hearing aid in, or they might not be able to understand your accent either. And patients, they might be in pain, they might be short with you. So you have to be able to take this on board as a learning opportunity. And so the student wasn't distressed by it at all. So what we did when we were moving forward is we got another teaching and learning grant for 2025. And we then decided to implement the chatbot into different stages of the curriculum. And it wasn't just in nursing, it was in public health as well. So we had first year, second year and third year nursing that we used subjects that we implemented this in, and also a postgrad subject in the School of Public Health, which is diabetes education and management. So for first year students, we did the Justin Davies scenario again, which is the diabetic patient with the foot ulcer, and we used it in class with the foot pedals, so the students could control it with the foot pedals for this year, and we had it in every class, so every single student in first year was exposed to it. The problem with this, though, was the ethics that I wasn't allowed to film. Because it was implemented into the curriculum, there was no opt-out for students. So students had to have experience with this patient. So I wasn't allowed to film it. I could observe, but I couldn't film it in case there was someone that wanted to not be part of the study. So I was able to get the transcript, and I've been able to read back through those conversations, and I've been able to do surveys on the students that wanted to be involved, but I wasn't able to film it, which was a bit of a shame. So that was first year. Second year we did, and now this was an optional, like an opt-in for the students. We ran it through STUVAC, which we call Simulation Week, and it was before their mental health placement, and we made a clinic situation. So it was a patient coming in for an outpatient visit with a mental health nurse, and we set up a clinic room. Patient was in normal civilian clothes, mannequin again in the chair, but it was a nice sort of warm environment, cups of tea, and the students were to do a mental health assessment. And it was a patient who was a Scottish expat being in Australia, feeling quite isolated, missing her family, and with some depression and anxiety symptoms. So they had to have a conversation with her. So that was the second year subject. Third year, this was really interesting. Third year was a critical care subject. So it was the critical care patient. It was a NICU patient, and it was the mother that was the patient that they had to converse with. She was 12 hours postpartum, and she had never been in a NICU situation before. So the students had to engage with her, reassure her, and explain what was happening to her baby. Sorry, Jane, I saw you had a question.
No, continue telling us how you used it, and I'll chip in after that.
Okay. So that was, so third year was really interesting. The conversations got a lot deeper in that, and the students were really quite challenging of the chatbot. They were really trying to push the boundaries there. Third, and then postgrad was in the Diabetes Education Management grad cert, and these students were using it remotely, but they had to use have an interview with a diabetic patient, and again in like a clinic sort of situation, and implement that. But then we also had the opportunity for that as a drop-in as well, where we set up the clinic situation like we did with the mental health patient. So with the clinic situations, the pedal was under the desk, and you would still control it with the foot pedal, and the computer was just on the desk to be able to hear it, and the mannequin would be next to the clinician, and there was a microphone there as well. So it was a similar setup to doing it at the bedside, but it was just put in an outpatient clinic sort of perspective. We found with the grad cert students, because these were students that were actively working in healthcare, that their conversations were even deeper because they've got experience with communication with patients already. The difference between the level of conversations with the first years to the third years was very noticeable in terms of how they progressed on their learning journey.
Jane.
Okay, I've got a few questions. The first one is, the first one's more of a statement. I think it's really great that you've combined different simulation modalities, so that AI chatbot with mannequins to enhance that sort of realistic nature of interaction. So applaud you on that. My second question is, how do we get foot pedal? How do we get the foot pedal set up? And I guess the third one is around costs and how you've managed that, because sometimes licenses are quite costly for large groups of students. And I'm interested, you said you've implemented it across nursing. And so I'm just wondering how you approached that.
So, I mean, essentially with the way SimConverse works is that the university purchases the license for the 12 months or for what the time is, and then you pay per conversation credit. And those conversation credits can go from 10 minutes, 20 minutes, as long as you want to have it. But then this is for the students to have their conversations remotely. And that's great because that student then gets individual feedback on what they've been doing and what they've said. When we did it in the classroom situation, I did it a little bit differently. I call it off-label use of the platform, but I would log in, or the tutor would log in the class, and it would just run on that one credit. So pros and cons of that is that, yes, we get the transcript, but you can't identify who said what, and you can't get individual feedback of SimConverse to that student. So for the first years, that was okay. We were able to, that was a trade-off that we were willing to have, because the students, we just wanted them to have the experience of Sim and actually having those conversations where they had to introduce themselves, they had to get consent.
But you could debrief them.
But you can debrief them,
Yeah.
yes, and you can go through the transcript later. It's just that, you would not have that individual feedback of what they did well, of what they didn't do well. With the drop-in clinics that we did, we had the option then of letting it run or doing individualized feedback. So then in terms of cost, you've got to work it out of how many credits we're going to use and how many students are going to be coming. If you've got a cohort of 600 students and each one is going to do that individually, then that was going to use up more credits. There was one other scenario that we did, with the first years before they actually came into the labs, we did a group scenario in one of their theoretical classes. So it was a tabletop activity where they had one group leader and they had 6 students in the group, and they had to come prepared with questions that they would ask the patient in an outpatient or a pre-admission clinic sort of situation. So they actually got to meet Justin before they came in to their labs, because this subject ran first. So they did that. So we were able to cut down on costs there because we were sharing 1 credit with the 6 students in the group. And that was logged on by the students. So they were able to get individual feedback in that, because you could then look at the transcript, and each one of them had to introduce themselves. So you could say, "Hi, my name's Dani." So in that part, that Dani is talking. So that was a good way as well of using it, a little bit more cost effective, not using as many credits, using 6 credits in a class of 24, or four credits for the class with 6 students, or however many students you had in the group. With the students that were in third year, again, we ran it like the first year. So we just logged in with 1 person. It just kept running. So we couldn't get the individual feedback, but it was interesting for me just to go through the transcripts all the same and see how the difference in language and the difference in depth of conversation went compared to the first year students. And then for the students in the grad cert, we did individual credits for them, but it was a much smaller cohort. So that's you're paying per credit.
So, Dani, can I just clarify that in terms of the credit, it can last all day?
It could
I thought it was
not all day
conversation.
No,
rather than
it does cut out, or I did it, or it starts to get a bit repetitive with the answers. So I would let it run for maybe an hour and a half, and then stop it, end conversation, and then start a whole new one. Because it's like the conversation agent, it's not like it exhausts all of its responses, but it just got a bit repetitive. So the experience wasn't quite as good. It's almost like he remembers what he's been saying and was getting a bit aggravated that it was getting asked the same question all the time. So it wasn't as authentic. So we would stop it and then do another one.
Authentic patient response, though. Yeah.
Yes.
Have you written any papers?
Sorry?
Have you written any papers?
I have. I've written a paper that's getting published in the Journal of Healthcare Simulation. We're just waiting for that. That was submitted back in October, November. So, and it's been accepted. It just hasn't been published yet. So that was just on the pilot.
Excellent.
It's just a short report.
We'll watch out for that.
Yeah, but there will be some more that comes out of this.
Very good.
As I continue on with the PhD journey.
Kerry.
Hi, Dani. Look, thank you for that. Now I'm gonna go back to the basics again. I'm a listener, listening to what you're having to say, thinking this is so exciting. I've never heard of SimConverse before. I have, but all right. So I'm gonna Google SimConverse. Tell me what I need to do from here on. How do I actually get this implemented in my program?
Well, you can look at the demos online. So there's SimConverse. They've got, if you Google it, it will come up if you're looking in sort of, Australasia, if you're in the UK or the US. The guys that created SimConverse, they're actually from Sydney. They're Sydney based. And their offices are not far from me, actually. So I can just wander on up the road. Initially, these guys came from University of Sydney, and they created it as a startup and have been working on it for quite a few years. It's in quite a lot of universities around. It's just a matter of the university purchasing the license. But when they purchase the license, it can be used. I mean, for us, it's faculty-wide. When UTS purchases, is everyone in every academic in the Faculty of Health will be able to implement it, and then it's just, as I said, how many credits that you're going to want to use. If you have 10,000 credits or less than 10,000 credits, there's a certain price point. But once you go over 10,000 credits, then it brings that price point right down, and it's a more cost-effective option if you've got that volume of students. So it's just a matter of getting the license and working out, how it's going to be used and if it's cost-effective for the university.
Right, so I've now convinced the university that I'm going to be able to use SimConverse.
Yep.
So I've got mannequins in a classroom, but I've also got role play of students jumping in and out of beds as well. Tell me how I might apply that then I'm asking the real basics.
Yep.
How do I then apply that to mannequins? How are you getting these stories to be connected to these mannequins, or even if I was using role play?
So there's a library of patients that SimConverse already has. There's, you can go in there and find, okay, what are the benchmarks that the students have to achieve in this class with that sort of simulation, and you can find one that's very similar. Or there is training on the academic end of creating your own patient character. So for us, we've created our own because we had in the curriculum already certain patients that they needed to the students needed to work with. So with Justin, for example, he was newly diagnosed diabetic, outside the healthy weight range, and needed some depression and anxiety. So we wanted him to be part of the UTS community. So I made him his character. He lives nearby. He had a bit of a backstory that he'd, been divorced by about a year ago, and just building in all of these things. So SimConverse found me a character that was like that. And then I learned all the prompts that I would need to put in, typed in the prompts, and I can tell you Justin has evolved a lot from 2024 to 2025. He's now got a full arm of tattoos, a full sleeve, and the students can ask him about that, and he'll tell the story of why he got these tattoos, and which is, really quite interesting. He's, as I said, he's a bit of a conspiracy theorist, so you can build up. So the more the character knows about itself, the more information it's going to give. If you keep it generic, it's going to give generic answers. The more you build it up. So the academics themselves actually get training from SimConverse, from the education team, of how to create the characters, and then how you create the activity. And then you set that activity for the students to use. You can embed it in Canvas or whatever teaching platform you use. And they then it's just a matter of clicking on the link or logging in to SimConverse. You have to, the subject coordinator would have to load in the email addresses of the students of who is going to be using it, for those students then to be able to access it. But it's not hard to create a profile on that. I did a quick little video of me using SimConverse for my teaching staff to be able to learn how to log in. And that was it. Pretty simple. You just put in your email address, it sends you a code, and you just click on the activity you need to do.
Very good. So to wrap up, Dani, I know you're doing your PhD, so you might not want to give too much away, but future directions.
So my interest is really in communication confidence of students. As I said, the example from my daughter, from my 15-year-old, I'm really interested in how we can develop that, and if we can, if it is something that we can start to build on by using these conversation agents. So I want to be able to get to the point of developing an OSCE by using this. So when we do an OSCE, and we are usually it's the way we're doing it at UTS, it's on the mannequin patient, but the assessor is the voice of the patient, and I can find that can vary quite a lot with how much the assessor speaks. So I'd like to be able to standardize the patient voice by using this sort of technology and the foot pedal of and having that patient scenario very standardized by using the chatbot to do that. And then the assessor is only then speaking when they need to, if they need to be the person checking medications or something like that. So I'd like to do an RCT with X amount of students using it with the chatbot, and X amount of students doing with the assessor, the human assessor. So I'd like to see I want to see what and then I want to do some surveys and in-depth interviews of what the students thought if they were in this group or if they're in that group. So that's what I'm sort of working towards. Obviously, it's tricky with an OSCE because you have to have it has to be equitable for all students. So I want to make sure it's right and we haven't got technical issues happening. So there's a bit of work to do on that front. Back to Jane's question about the foot pedals, where do you get them? We just got them from Amazon. It's pretty easy. Although I nearly got the school's credit card shut down because they thought I was buying spyware, all spy equipment. When we were using the funds from our teaching and learning scholarship, they thought, why are they buying foot pedals and weird microphones and things like that? But once they understood what it was for, it was much more accepted. So, most of the products we got was my engineering colleagues sourced all of those. And we've got it set up to run 6 bed spaces at the moment. So we've got enough foot pedals. So I like to have one either side. So 2 foot pedals, 2 microphones, one at the head, one at the foot of the bed, and a foot pedal on either side. And we just set it up in the bed spaces that have computers near them. So hoping to be able to run it in a lot more subjects this year. That's the plan.
Amazing work, Dani. Jane and Kerry, any last questions or thoughts?
I think it's amazing, Dani, and I think great job sorting out the how the foot pedals and things like that. Great innovation there.
Yeah, looking forward to read more.
Yeah, thank you. I work quite closely with the guys from SimConverse, and they're happy to support this different kind of way of using it, because for them it's they're really interested in just all the different ways that we can teach and that students learn in terms of communication. So it's been really fun, and it's great to come to work and be able to use this kind of technology and the experimentation that we get to have. So it's really quite rewarding.
Excellent. Well, it's early morning and I'm sipping my skinny flat white. But we ask all our guests this, Dani, if you could have like happy hour anywhere in the world, where would it be? And what would you be doing and sipping?
What would I be sipping? What time of day is it?
Any day, any time you like.
Yeah. Look, I haven't had a holiday for a while, so I think I would like to go somewhere tropical and read a book that's for entertainment, not a book
for
study. So that would be really nice, somewhere warm by a pool. But then I'm also, a bit of a skier, so I wouldn't mind sipping somewhere in the French Alps, après skiing as well. So
cool.
I think I'm going to go with the après ski in the French Alps.
Very nice. Great job. All right. Well, that wraps up another episode. Thanks for joining, Dani, and Kerry and Jane. We'll see you next time.
Wonderful.
Thank you.
Thanks, everybody. Bye.